with this, I would like to start the talk on the topic that is given today. It is an interesting topic, that is secondary osteoporosis. Now, osteoporosis as such is an interesting area for orthopedicians and endocrinologists as such. And on this, I would like to start the talk with a few cases. I'm going to discuss osteoporosis with a few case presentations. So the first case I have to take that of a 48-year-old male who presented with a history of recurrent upper respiratory tract infection. His absolute eosinophilic count was high. CT chest and PET-CT showed medial canal lymphadenopathy. Patient was advised further investigation. The patient dropped out. He came for follow-up again after 3 years. In between, outside he got diagnosed as having sarcoidosis, and he was started on prednisolone 15 milligrams per day. When patient came to us for follow-up, he was found to have also have diabetes, hypertension, and was started on oral anti-diabetic and antihypertensive drugs. Glycemic control was reasonable, not very bad. Once the patient came, we started tapering the prednisolone, and slowly it was tapered down to 2.5 milligrams per day. And patient, once the prednisolone was brought down, patient became euglycemic on lifestyle modification. Oral antidiabetic drugs were completely withdrawn, and he didn't have any complaint of back pain, but he had a history of fracture of the right clavicle that happened 1 year ago, and that was due to a road traffic accident. He also had history of smoking and alcohol consumption. However, he did not have any history suggestive of hyperparathyroidism, like renal stones or proximal muscle weakness. Some proximal muscle weakness was already there. He did not have any other history of progenitive fracture, and there was no family history of fracture. Like on examination, he was not lean. BMI was 50.8, and there were no bone tenderness. The biochemistry in the lab were more or less normal, except that vitamin D was around 98 nanograms per ml. That is quite at the upper limit of the safe level of vitamin D. So this patient had the diagnosis of sarcoidosis with steroid-induced diabetes mellitus, secondary hypertension, and secondary osteoporosis. When the patient came to us, the X-ray of the lumbar spine showed only non-specific age-related changes. Fracture score showed the risk of major osteoporotic fracture at 8% and hip fracture risk of 2.4. He was started on IV bisphosphonate. Now we'll come back whether it was the optimal choice or not. And after 6 months, he complained of some back pain, and because of that, at that time, we had to repeat one X-ray of the lumbosacral spine. And this X-ray showed the fracture of L1 vertebra. So with this, we'll come to the osteoporosis as such. The secondary osteoporosis is basically low bone mass with micro-architectural alterations in bone. It can lead to fragility fracture in the presence of an underlying disease or medical. It can affect women and men. Normally, the osteoporosis as such is supposed to be a disease of women, that too in the postmenopausal age. But secondary osteoporosis can affect both premenopausal and postmenopausal women. And if we try to look at all the patients who have osteoporosis, at least 30% of the postmenopausal women and 50 to 80% of the men who have some other factor which will be contributing to osteoporosis. In short, this is the prevalence of secondary osteoporosis. So why evaluate for secondary osteoporosis? The reason is that the treatment for secondary osteoporosis might be different than what we will take it as treatment for distinctly postmenopausal or senile osteoporosis. One simple example is carcinoma or any other condition which leads to hypercalciuria. So hypercalciuria treatment, unless we treat hypercalciuria, the treatment for osteoporosis, the treatment for hypercalciuria like indapamide or thiazide, till that time the treatment for osteoporosis will not. So that is reason number one. Then the undetected primary disease can be, if we evaluate every case of osteoporosis, the undetected primary disease can be diagnosed and can be treated. Some of them can be quite troublesome, like multiple myeloma, leukemia, Cushing's disease, and hypercalciuria. Sometimes presence of osteoporosis and secondary osteoporosis can predict the course of the primary disease. Now, in some of the conditions, it is known that osteoporosis, association of osteoporosis is associated with worse diagnosis for the primary condition. So that is for multiple myeloma, it is especially known. And that is if a patient with multiple myeloma has osteoporosis and has osteoporotic fracture, the mortality is higher in these cases. And some of the patients who were followed over a long period of time, that happened with the Women's Health Initiative cohort, when these patients were followed, it was found that the patients who had developed multiple myeloma, those patients who had developed multiple myeloma and had a higher SNAT score or a lower BMI, these patients later on had worse outcome. So, diagnosis of osteoporosis with a primary disease can mean worse outcome, and associated osteoporosis even before the onset of the primary disease could also be associated with the worse outcome. So, it affects both the primary condition as well as the osteoporosis. The evaluation has significance for both. Now, glucocorticoid use is quite common. We all of us know, and with this pandemic of COVID-19 going on, the glucocorticoid use is rampant now. It was from the US, the data was that at least 1% of the population of the US was on long-term glucocorticoid. Many medical conditions which require use of the glucocorticoid can also predispose the person to the osteoporosis. And the risk of fracture with glucocorticoid use is associated with the dose of the glucocorticoid and the duration of the use. More risk for fracture or secondary osteoporosis with glucocorticoids is associated with number one, the continuous use, number two, post-menopausal treatment, and people who are late. Those who are using glucocorticoids for intermittent periods, those who are younger, usually have less risk with the glucocorticoids. BMD and SAT score in general are not reliable predictors for fracture with the glucocorticoid use, and this we will see many places in the secondary osteoporosis. Estimated prevalence of vertebral fractures, whether diagnosed or undiagnosed, is found to be somewhere around 35% of patients who have been using a significant dose of the glucocorticoid, such as 7.5 milligrams per day, or equivalent of prednisolone or prednisone over a period of 3 months or more. This prevalence is around 35%. And the drugs which are generally recommended for treatment of glucocorticoid-induced osteoporosis are anti-resorptive drugs and teriparatide. So there is a recommendation from the American College of Rheumatology regarding the glucocorticoid use and the treatment and prevention of osteoporosis related to glucocorticoid use. And this recommendation came in 2017 recommended that all patients who are given glucocorticoid in any amount should be evaluated. The first evaluation should happen at 6 months, and the evaluation should depend upon the age of the patient. If the patient is less than 40 years, then the evaluation includes BMD or the history of any past history of fracture. If patient has any past history of osteoporotic fracture, then patient immediately moves into the moderate to high risk for osteoporosis. If patient doesn't have any past history of fracture, but the patient has low BMD, that is Z score is less than 3, then that patient will come somewhere in the mild risk for osteoporotic fracture. But this risk changes for patients who are more than 40 years of age. And the treatment for glucocorticoid-induced osteoporosis is to be started based on the original risk evaluation. The original risk evaluation also looks into other risk factors for fracture. These include the family history, presence of hyperparathyroidism, presence of thyrotoxicosis, whether the patient is lean, whether patient has previously had any other fracture, hypercalcemia, all these other risk factors will also come into the picture. And if once the patient is evaluated, after that patient will require a re-evaluation once every 2 to 3 years. Earlier re-evaluation may be required for patients who have sustained either a fracture in between or who have had a rapid fall in the BMD that is more than 10%. So, depending upon the evaluation, patients may require those who are on the moderate risk and those who are on the low risk. Those patients who are on the low risk require calcium and vitamin D only. Those who are at moderate to high risk will require the therapy, and the therapy is in the form of bisphosphonate and teriparatide. The bisphosphonates which are recommended for treatment of glucocorticoid-induced osteoporosis are oral bisphosphonates, And oral only if the oral bisphosphonates are not working well, then only we go to the intravenous bisphosphonates. Otherwise, oral bisphosphonates are the treatment of choice. And after that, we can go to teriparatide if there is a problem further. This recommendation is for the women of more than 40 years of age, women of childbearing age. We have to be careful. And this is, of course, the bisphosphonates are not permitted. The treatment is not permitted in this society. So I will come back to our case. So this case, this gentleman, when he came to us in 2016, his PMD was minus 2.7. His score at that time was minus 2.7. In 2017, around 2017, we started him on IV bisphosphonates. Actually, we tried with the oral bisphosphonates, but there was a problem of the compliance, so we moved to the IV bisphosphonates. Zoledronic acid was given, and with that, the PMD remained more or less stable. In the beginning, it looked like that the PMD has changed, but after that, the PMD did not worsen and did not improve either. And patient has not had any further fracture at that point. So the oral bisphosphonates are the first treatment, and only if they fail or if there is a problem with the compliance or if there is a doubt that the absorption is bad, then we go to the IV bisphosphonates in these cases. Glucocorticoid-induced osteoporosis, the major fracture is at the vertebral, and the non-vertebral fractures are relatively less common. And the bisphosphonates are shown to have very good effect at the vertebral fracture, but at the non-vertebral fracture side, also some benefit is there. It is not that they are without benefit, but the benefit is most on the vertebral fracture. Now, Denosumab is also been tried and is found to be successful. So this is a trial which came in 2018. This is a multi-center trial in which some 900 patients were taken and were divided into two groups. These patients were into two groups. One group was the patients who were glucocorticoid continuing, and the second group of patients who were glucocorticoid initiated. So the initiated means that the patients who had taken glucocorticoid for a period of less than 3 months, and the patients who are glucocorticoid continuing were the patients who are on glucocorticoids for more than 3 months. The minimum dose permitted in this study was 7.5 milligrams. Anybody who had taken 7.5 milligrams of glucagon or prednisolone was eligible for this study. So 500 cases were there in the group which was glucocorticoid continuing, and they are our main area of research today. So for recruitment, they also had to have age more than 50 years with low BMD, or age less than 50 years if the person had some fracture. And the age distribution was, the mean age was 61 years, and the sex distribution was that majority of the patients, 70% of the patients were women. The diseases for which these patients were receiving treatment were rheumatoid arthritis, polymyalgia rheumatica, COPD, bronchial asthma, the routine things that we see for these cases. So the age was less than 50 with fracture or more than 50, and if the age was more than 50, the T-score of less than 2 was the criteria for improvement. Now the Denosumab, the comparator group was risedronate 5 milligram per day or Denosumab, and these patients were on dummy. So the patients, this trial lasted for 2 years. Those patients who are on Denosumab, they were receiving Denosumab 60 mg every 6 months. And those patients who are on risedronate, they received a placebo every 6 months for next 2 years. And those patients who are on Denosumab received a placebo of a small tablet which they had to take every day morning. So at the end of BMD was repeated at the end of 1 year, and both turnover markers were seen at 3 months, 6 months, and after that at the end of 1 year, and then at 2 years. And those patients who are continuing the glucocorticoid, that is our main area of interest. Both the groups increase the BMD. The patients who are on risedronate, that is visible in the pink bar, these patients had gained the BMD. The lumbar spine BMD was gained at 6 months. 2% gain was there, while at 1 year the gain was 2.3%. The patients who are on Denosumab, they gained 3% BMD for 6 months, and they had gained 4% BMD at the end of the 12 months. Now it looks quite significant, but the design of the trial was non-inferior. So all we can safely say is that Denosumab was not found to be inferior to risedronate in this group. And then we see the association of fractures and other adverse effects. So one adverse effect which was quite associated with the use of Denosumab and with the risedronate was basically associated with the use of glucocorticoid, that was the infection. But when we see at the other fractures and other fracture related events, so the area which I am showing the column on the right hand side is the Denosumab group, and we see that the non-new and worsening vertebral fractures were seen in approximately 1% of the patients who are on Denosumab against 3% of the patients that is made. Again, non-inferiority design. So Denosumab was no worse than Lisidone, and the new non-vertebral fractures, they were also seen similarly, 3% and 4%. Now, when we are talking about the new fractures, when this population was taken, the established prevalence of fractures in these cases, the vertebral fractures, was around 30%. That the average duration of more than 60% of the patients had used glucocorticoid for more than 1 year, and the average dose of glucocorticoid was coming to somewhere around 12 to 13 milligrams per day. So this is quite this is data which this is our patients will be fitting in this kind of dose that we see in the OPD basis, and this trial suggests that Denosumab is also not worse than Lisidone, which is quite a lot used for treatment of glucocorticoid in use of osteoporosis. So with this, I will go to the next case in the presentation today. The second case is that of a farmer who came to the neurosurgery OPD. He was told that he had backache and some back problems, so he decided to come to the neurosurgery OPD, and it showed a L2 vertebral compression fracture. So the surgeons were deciding whether to go for any procedure for the vertebral compression, but he was referred to the endocrinology OPD for further evaluation, and that is how the fracture looked like in the X-ray. So when the detailed history was asked, patient also had type 2 diabetes, and he also had a past history of a thyroid disease. 2 years ago, he gave a history that he had taken some treatment for a thyroid disorder. But for the last 2 months, he had exceptional palpitations and involuntary weight loss. He also complained of increased sweating. There was no history of steroid abuse and no history of hypothyroidism. His thyroid was enlarged and firm, and when we did the evaluation with the thyroid function test, his T3 was on the higher side, but it's still in the normal range, and his T4 was almost 2 times that of the normal range for our lab. ESH was suppressed. So this was a case that we were dealing with a case of thyrotoxicosis. And when we did the technetium thyroid scan, it showed the diffuse bilateral exclude mildly increased uptake. BMD was done, and BMD showed only minor change. It was minus 2.3 in the lumbar spine AP, and the hip neck showed minus 2.2. So the BMD was on the lower side, but not quite bad. So we knew that we are dealing with a case of Graves' disease with diabetes, type 2 diabetes, and secondary osteoporosis. Patient was started on carbimazole 20 milligrams per day. He was taking only a low dose of metformin for control of his diabetes, and he was once we repeated the thyroid function test after 1 month, the T4 had come down to quite lower level, so his thyrotoxicosis was very high. So this was a case of thyrotoxicosis associated with secondary osteoporosis. Thyrotoxicosis is known to be associated with hypercalciuria. Hypercalcemia is more common. Hypercalcemia is still seen, but it is seen in a less number of cases, maybe around 25 to 30% of the cases only. Hyperphosphatemia is also there. Thyrotoxicosis is also associated with increased bone turnover, and the bone turnover markers are also increased in thyrotoxicosis. Now, it is known that T3 activates the osteoclast, and the T4 supplementation, the high T4 anyway activates the osteoclast, but T4 supplementation to patients who are hypothyroid, even with the serum T4 in the normal range, is also known to be associated with the bone loss. And let us just forget about the patients who are on suppressive doses of thyroxine for treatment of carcinoma thyroid. They anyway have bone loss. Role of ESH is also supposed to be there in patients who have thyrotoxicosis. ESH is also supposed to be one of the factors involved for activation of the osteoclast. Of course, in Graves' disease, as ESH is anyway low, so that is not supposed to be a problem. Thyrotoxicosis associated osteoporosis is worse in the patients who are postmenopausal and lower the bone mass in the starting, worse is the outcome for thyrotoxicosis. Recovery for patients with thyrotoxicosis happens for most of the patients, but that recovery will not be adequate, may not be adequate, especially in the post-menopausal women, and they may be left with a residual weakness in the bones. So with this, I come to the last case today for discussion. So this is a 62-year-old lady who was evaluated for shortness of breath. She came with a CT chest, and there was evidence of, in the CT, there was evidence of multiple ill-defined lesions in the vertebrae. She also had history of back pain. There was no history of fracture or joint pain or hematuria. There was no history of increased renal. She was further evaluated, and the calcium was normal, but serum albumin globulin ratio was altered, alkaline phosphate was elevated, and on further evaluation on the electrophoresis, it was found that she had M-band as well as immunoelectrophoresis to IgG and kappa light chain. Bone marrow aspiration and biopsy was done, and it confirmed that we were dealing with a case of multiple myeloma with IgG. So she was started on chemotherapy, and chemotherapy also included dexamethasone. She was on chemotherapy with dexamethasone, and because it was already understood that she also has multiple myeloma with the osteoporosis, she was also started from the beginning. So she is continuously getting the chemotherapy. She has not had any fractures, no renal stone, but low backache is still present. A calcium profile for quite some time has been normal. So that is how her X-ray scan was there, even though it shows some less bone density, but it is not showing any fracture. So multiple myeloma as well as monoclonal gammopathy of unknown significance. Both these conditions are associated with low bone mass and osteoporosis. They can have osteolytic lesions, and skeletal X-rays can pick up lesions in 40% of these cases. BMD can be done with DEXA, it can be done, and it can pick up the low bone density. But for some reason, bone scan is not very good at picking up osteoporotic fracture in these cases. Probably because these lesions are not osteoblastic, they are osteoplastic lesions, basically. The treatment for multiple myeloma and monoclonal gammopathy associated osteoporosis is again this possible. So with this, I will just before we end the session, I would just like to mention a few other diagnoses, other causes of secondary osteoporosis. That is, then we have hypogonadism. Hypogonadism is the commonest cause of osteoporosis in men. For that matter, it is the commonest cause of osteoporosis in women also, because that is what actually is postmenopausal osteoporosis. But because it is so common, so we don't consider it as secondary osteoporosis. It is the commonest cause of osteoporosis in men. And the treatment of hypogonadism associated osteoporosis is, number one, if possible, replace the androgen for men, and after that, if that also doesn't work, or if there is a contraindication to androgen therapy, or because these elderly men are often more susceptible to androgen, might be because of the prostate problem, might be because of the hematocrit rise, then these patients are often shifted to bisphosphonate or Denosumab. Then one more cause for secondary osteoporosis is primary hyperparathyroidism. Quite an important cause, but I am just mentioning it in passing because most of the time we pick up primary hyperparathyroidism because of the associated hypercalcemia. But sometimes it might still be picked up during the evaluation for osteoporosis. Primary hyperparathyroidism basically causes increase in the bone turnover, more osteoclastic action, more osteoclast. But that because of the turnover is rapid, the osteoclast the bone laying down cycle becomes shorter and the bone resorption becomes faster. So these patients are more affected. The fracture risk is more for the vertebrae, and Dr. Paresh already asked one question on primary hyperparathyroidism. So the vertebral fractures are more common, but the other sides can also be affected, like this ankle, wrist, pelvis. Primary hyperparathyroidism will also be associated with other features of hypercalcemia and hypocalcemia, like the kidney stones and all. The treatment for primary hyperparathyroidism associated osteoporosis is, number one, the surgical treatment for the hyperparathyroidism. one of the indications for hyperparathyroidism for surgery for hyperparathyroidism is osteoporosis itself. Then after that, the treatment is for bisphosphonate. Bisphosphonate will take care of both hypercalcemia as well as osteoporosis. And in some of the cases in women, if it is a problem, hormone replacement therapy can be done. Then, in the end, I would like to mention a little bit about diabetes mellitus. Diabetes mellitus, commonest condition, type 2 diabetes and type 1, both of these are associated with osteoporosis. Now, the BMD in diabetes mellitus depends on the kind of disease. Type 2 diabetes is associated with increased BMD, but even though the bones are thick and they look more strong, they actually are porous bones, and probably there is a lot of advanced glycation and product, and there is also activation of the cytokines. So these bones, even despite having high BMD, these bones are more fragile. They are more likely to fracture. And of course, type 1 diabetes, where insulin is deficient and patients are lean and thin, there they have less BMD and the bones are fragile. Of course, BMI, higher the BMI, the BMD is likely to be slightly better. And the medication, insulin use as well as thiopentazole. Now, insulin is quite good for the bones, but still in type 1 diabetes, insulin deficiency is there, and type 2 diabetes, insulin resistance is there. So both these conditions are associated with osteoporosis. As a medication, the patients who are on insulin are more prone for having osteoporosis, as well as the one medication which is quite not so commonly used now, but thiazolidinediones, because previously used quite a lot. Thiazolidinediones was conversion of or the diversion of the mesenchymal stem cells into the osteocyte proliferation site and less movement into the osteoblast laying down site. So the marrow is basically full of fat and less osteoblast. So there also risk for secondary osteoporosis is high on the patients who are using thiazolidinediones. Fracture risk in patients with diabetes depends upon the duration of the disease as well as on the insulin use, and the treatment. Of course, the treatment of osteoporosis is there, but one very simple thing is avoid fall. And elderly patients who are more prone for fractures, we have to make sure that they don't have the associated problem which can lead to increased fall. Like especially one of the common medications that we are using right now with the SGLT2 inhibitors, as well as we have to make sure that they don't have postural fall. If they have postural fall, they need to be treated for that. So with this, the secondary osteoporosis part and the diabetes mellitus have concluded. So with this, I come to the end of the presentation. I would like to conclude the presentation by saying that the secondary osteoporosis is common. Glucocorticoid-induced osteoporosis is the commonest form. Glucocorticoids are particularly troublesome because they increase the resorption while they suppress the new bone formation, as well as the marrow is full of fat, the calcium, vitamin D, everything is affected with the glucocorticoids. Other causes and drug-induced forms, even though are less common, but still these are quite important parts. Prevention and treatment of osteoporosis is to prevent deformities, and the basic treatment is calcium and vitamin D, and wherever required, oral bisphosphonates are required for treatment. And treatment of the primary condition which has caused osteoporosis is important. So with this, I conclude the session. I request the chairperson to take